Good evening, everybody. Welcome to the master class, which we conduct every Tuesday as a part of the critical care program from the Yashoda group of hospitals. So this Tuesday, we bring across a new case. So we are going to discuss a case of meningoencephalitis. So for moderating this session, we have Chief Examiner Dr. Gaurav Kakkar sir, who is a senior consultant, lead neuro anesthesia and neurocritical care from Amrita Institute of Medical Sciences, Faridabad, one of the very largest group of hospitals in Faridabad. And we also do have Dr. Durgesh Satalkar, who is a senior critical care consultant from Yashoda Hospital, Secunderabad, who exclusively practices neurocritical care actually. So the case would be presented by Dr. Jeevan and Dr. Hina, who are students from Yashoda Malakpet. So over to you, Dr. Jeevan and Hina.
Good evening, sir.
Good evening.
Myself,
Good evening,
Dr.
sir.
Jeevan Reddy. So, a 31-year. Actually, 1 second, sir. Sorry for the inconvenience, sir. A 31-year-old male who is a resident of Nagar Karnool, teacher by profession, came to our emergency department with complaints of fever since 7 days, headache since 7 days, and vomiting since 7 days, with irrelevant talk of 1 day, sir. History of presenting illness. The fever is of high grade in nature, with associated with chills and rigors, severe body pains, and generalized weakness. Headaches in 7 days, which is diffuse in nature all over the head, and vomitings for 7 days, 3 to 4 episodes per day, which are projectile, non-bilious, and containing food particles, sir. So at that point, he went to a local hospital and admitted there for 3 days. However, symptoms have not subsided, and there is a 1 day history of irrelevant talk since yesterday, since 1 day, sir. There is no history of seizures, giddiness, loss of consciousness, ear pain or ear discharge, and recent trauma, sir. His past history is no history of any comorbidities and not on any regular medication, sir. Personal history, his bowel and bladder habits are regular and takes mixed diet, and history of alcohol intake occasionally. Recent heavy alcohol intake is there, sir, and he's a non-smoker. And family history is not significant, sir. Our differential diagnosis at history are meningoencephalitis bar meningitis, subarachnoid hemorrhage, encephalopathy, septic bar metabolic, and heat stroke, cerebral malaria, alcohol withdrawal, and dyslipidemia, sir.
So Dr. Jeevan and Dr. Hina, let's hold on at this slide. So just by your history, which way is your diagnosis differential heading?
So
Any
it is
specific direction just yet?
more towards neurological CNS
Altered sensory.
central nervous system like presentation, sir.
Mhm.
So because of headache, vomitings, and fever, headache, and vomitings associated with altered mental status is more of meningitis or meningoencephalitis, sir.
There's most
And-
chances of CNS involvement, sir.
And sometimes in a case of subarachnoid hemorrhage also there is a headache with vomitings and associated with mild to low
Fever.
fever is also will be there, sir, and there could be an altered mental status. And as there is a alcohol intake, recent alcohol intake, and he's an occasional alcoholic, there could be an alcohol withdrawal, wherein there could be an altered irrelevant talk, sir.
From
Mhm.
headache and
And,
sometimes fever also might be present.
And heat stroke, especially in the season of summer, where when they go out, there is a the raised temperatures can cause fever and headache, and that raised temperatures can also lead to febrile encephalopathy and or altered sensorium, also possible with the heat stroke, sir. And because ours is a tropical country, we are suspecting possibility of cerebral malaria also, sir. And for irrelevant talk, any altered symptom, there is possibility of dyslipidemia. So we have kept our differentials in this way, sir.
Okay, so what is the difference between meningitis and meningoencephalitis? If I
So
may
in
ask.
meningitis is more of an inflammation of the meningeal
Meningeal.
protective coverings of the brain. So in that there
Okay.
could be fever, headache, and fever,
Head-
neck stiffness, and there
head.
could be altered mental status, sir. In encephalitis, there is an involvement of the brain also. So meningoencephalitis, there is meninges and encephalitis, spread of the meningitis into the encephalitis brain tissue. So in such scenario, there could be even seizures and focal neurological deficits are also can be possible, sir.
So what do you have in your history for these two?
Fever,
Fever, headache, and
altered sensory.
vomitings, projectile vomitings, and altered sensories.
Okay. So encephalitis is when the brain parenchyma starts to get involved. And the
Yes.
most common presentation would be?
So behavioral abnormalities.
So either seizures or
Focal
altered mental sensorium can be there in all of this, but the most common one among the top is the seizures presentation
Yes.
when the cortical surface gets to get involved in infections.
Yes.
So the other things that you've said for the remaining things are true, but the treatment different doesn't, the treatment paradigm remains the same,
Yes.
but your urgency to treat starts to get more focused when you see the signs of encephalitis as well.
Yes.
Okay, and anything else in your differential that you've covered heat stroke, cerebral malaria, anything else in this malaria section as a big umbrella for our subcontinent that could be there?
Falciparum malaria. Sir?
I'm sorry, sir.
Sir, could I?
Any other so malaria is a
Okay.
Tuberculosis
endemic part of
meningitis.
tropical
Tuberculosis
illness.
meningitis in our subcontinent.
So in our subcontinent, we have a whole host of tropical illnesses that affect the central nervous system.
Yes.
They also are seasonal as well.
Yes.
Especially with the onsets of rains and monsoons, a lot of encephalitis, especially the viral one. So, you can, in your differential as an examination, you can subdivide into infective pathologies, you can subdivide into non-infective pathologies, and the non-infective can then go down into the heat, alcohol, electrolytes, traumatic. So there is a saying for exams when you answer questions, it is classify or die.
Okay.
So that gives a clarity to the examiner when you're answering that you've thought through and there is an organized way of looking at things.
Okay.
Okay. So infective and non-infective, and the non-infective, then you can further branch off. In the infective, of course, you have
Meningitis, meningoencephalitis.
and then you can further divide them into the etiology of those
Bacterial,
without going
viral,
into them.
aseptic.
Okay, anything you want to ask, Dr.
Yeah. Apart from that, look, this has already been covered, but the sepsis is also important part. Not only when we are focusing on meningitis, means that our differential diagnosis should not stick to only meningitis, meningoencephalitis. So there are probably sepsis. Maybe you say fever, headache, and though meningitis and all this come first in your mind, but other differential diagnosis, other part of sepsis. Suppose probably the patient, though this patient has no any comorbid condition, or suppose a patient with uncontrolled diabetes, or they may have urosepsis but septic encephalopathy. So don't come down the differential diagnosis to particular. Suppose the topic is today meningitis, so diagnosis should whole encircle it. What could be other apart from this? Already sir told tropical fever is also one of the differential diagnosis in this our scenario.
Absolutely good point, especially when your patient, you did say in your slide, this patient has spent 3 days in another hospital.
Yes.
Did I get that correct?
Yes, sir.
Yes, sir.
So you already have a patient coming from a home setting, he was unwell, and then coming from another hospital.
Yes,
So most common problems, dreaded problems of our hospitals are hospital-acquired infections.
Yes.
So he might not have all this. He might just be septic from another hospital coming in. So he just purely can be a pure septic encephalic patient, and not straight away have that. So you need to have a broad brush right at the start. Okay.
Yes.
So our history gives us most of the clues, and our history has to be extremely, extremely detailed.
Yes.
It has to come from initially, you might not have all the people giving you the history, especially in acute setting uh, when the patient has just come. But we must go back to the patient's relatives or whoever is brought to get as much details as possible. Just a first responder history is never sufficient in ICU. You must go back to get the actual history. You might get new leads. You might get all the medicines also. Especially this guy is young. You might have elderly people who probably are on polypharmacy and have missed their medications and might simply have electrolyte abnormalities or they've mismanaged their medication. So you must go back to confirm the initial history in ICU and note down the medications. And many a times you will get your 50% of the direction you'll get from the history itself. And there is something specific that which I thought was missing in your history coming to this diagnosis, which might I'll bring it out as you go along. Let's see. Okay, carry on.
So on examination, general physical examination, our airway is patent, sir. Breathing, respiratory rate is of 26 per minute and SpO2 of 96% on room air. Bilateral equal area entry with right bilateral normal vascular breathing and right infrascapular fine inspiratory crepitations are present, sir, right side. Regarding circulation, pulse rate was 90 per minute and blood pressure was 110 by 60 mm of Hg, sir. And
So how is you assess the airway in a semi-conscious patient? If he's altered sensorium, how do you assess that airway is patent?
so when he is an irrelevant dog, he is opening his mouth. So there we can say that his airway is patent, sir. But when it is not, there cough reflex and we will assess for cough reflex and thyromental distance and
Just go back to your previous slide, please, if you don't mind. Okay, so you're saying the patient's talking to you by irrelevant, so patient's airway is okay.
yes.
What if he was more drowsy and he was not talking? He was just semi-conscious. There was no irrelevant talk.
So any pulled up secretions, cough reflex is present or not, any pulled up secretions are there, we will be looking for them, sir. If there are any pulling of secretions and if the cough reflex is decreased, then we can think that the airway is threatened, sir.
Okay. And in your circulation, anything else apart from pulse and BP?
JVPs.
There is JVP or capillary refill time.
Extremely important.
Okay.
In circulation assessment of a patient who's septic or query septic, you general physical examination starts from the fingers.
Okay.
It starts from the eyes. Yes, we don't go to the systems just yet.
Yes.
So, how does the capillary refill is affected in sepsis patients?
So in a setting of septic shock, there will be an increased capillary refilling time, sir. Generally, it should be 2 to 3 seconds. It will be extended, sir.
So your circulation needs to be a bit more than just pulse and BP, na?
Yes.
This, so your triage nurse will take pulse and BP and give it to you. So you want to know how warm or cold your patient is, how cold or warm the extremities are. If the peripheries are cold and the central core is warm, what does that tell you?
So cold clammy peripheries indicates that central warm and peripheries are cold means there could be some cardiogenic shock. And even in vasodilatory shock also, in the late settings, there will be cold clammy like septic shock. Later stages, there will be cold and clammy periphery, sir.
So not straight away shock.
Yes.
The patient could be in sepsis surge if their peripheries are getting cooler. Might or might not be in shock, but that just shows that the perfusion is getting compromised. Anything else in general examination?
And
Okay.
disability and exposure we have seen. Sir. In exposure, there is a temperature of 101 degree Fahrenheit and there is no pallor, icterus, cyanosis, clubbing and lymphadenopathy, pedal edema, sir.
Okay, Dr. Durgesh, you can grill for the general examination if you have any questions.
General
Okay,
exam
so
seems to be like let's look the altogether as sir has said like detail slightly expected. Like as before or previously also, there was a missing point of capillary refill. You know, the recent trial was done. I think you might be heard of Andromeda trial. So the capillary refill, they have given equal weightage to as good as a serum lactate also. So even if you are monitoring or you are checking frequently capillary refill time, that is as good as your monitoring of the lactate. When you are evaluating the case of sepsis or presumed to be sepsis, so capillary refill time, temperature, that is means how the peripheries are. That is to be more important. Here also, you need to more elaborate. So just moving all four limbs, pupils reactive, and you have to be more elaborative. This temperature, temperature where you which temperature you are mentioning. Is it axillary or it is which side of temperature you are measuring? That point has to be also included in this.
And
Okay, and apart from this, just moving all four limbs like it's a power or all, that is also to be mentioned here.
Ricket, sir. Next slide is there, sir.
Oh, okay.
In detail. Yes.
Okay, go ahead.
CNS examination, patient is drowsy, arousable, obeying simple commands. With sensory examination is revealing intact pain, temperature, light touch, and proprioception bilaterally. Deep tendon reflexes, triceps, biceps, supinator, knee, and ankle were 2 plus, sir. Moving all four limbs with muscle power was 5 by 5. And there is neck stiffness present, and Kernick sign and Dubinski sign are positive. Bilateral plantars were extensors, and pupils were bilateral 3 mm and reactive to light.
okay, so till now, what you examined? Is your examination is finished, or there is another slide?
This is with the CNS, sir.
And we have just elaborated.
Okay, just finish your examination, then we'll talk about the examination.
Cardiovascular system S1, S2 hard and no murmurs and JVP not elevated, sir. Respiratory system, no visible chest wall swellings and pulsations or deformity. Bilateral chest movements are symmetrical. Bilateral variant present and fine right infrascapular inspiratory crepitus are present, sir. Per abdomen, soft, no guarding or rigidity, no organomegaly, sir.
Okay, so what are your positive findings on an examination then?
So mainly neck stiffness and Kernick sign and Dubinski sign are positive, sir. Meningeal irritation, signs of meningeal irritation are present.
Okay.
And there is right infrascapular crepitations, probably pneumonia consolidation, probably, sir.
Mm-hmm. So
Especially
that's just the neurological system. Anything else is positive? So don't just get bogged down by at this stage about a diagnosis. You have a patient you just received, you had a history and you're examining.
Yes.
In real life, you're not going to know the diagnosis. Okay, so it's good to go in a direction, but you must fulfill all the basic steps of history and examination. So, okay, you have a CNS examination positive points coming out from drowsiness with signs of meningeal irritation.
And planters,
But-
planters for extensions.
Okay, you have extensive planters. But in terms of your general examination, I'm not happy. Okay, your general examination of the patient is the one that guides you how sick or not sick the patient is and how quick, slow, or progressive your response needs to be. So your general examination needs to be detailed. You need to go back and look at what general examination means when you look and examine at a patient. So from top to bottom, can you tell me general examination? What were there? If you go back to your MBBS days, how do you do a general examination?
Okay.
Head to toe, we have to check the head from the hairs, the pattern of the color of the hair, the distribution, is there any alopecia or anything. Then even the eyebrows have to be checked, the eyes for pallor, icterus or anything. Then any bluish discoloration of the nose, the lips, any cyanosis. Even the ears have to be checked for any discharge or anything. In the neck,
So I
JVP.
didn't see any cyanosis or negative examination for cyanosis. Okay, I didn't see any pallor icterus. I didn't see any eyes being examined properly. Okay, go ahead. Dr. Hina, go ahead.
So no pallor, icterus, sinus clubbing, lymphadenopathy we have mentioned, sir.
As a no pickle. Okay,
Yes.
right. Okay, go ahead, Dr. Hina. Go ahead with the general
neck
examination.
with the we have to check for the JVP, sir. Is there any raised JVP? And then on an
Before you get to the JVP, stay on the face. Anything?
Any
Parotid swelling.
parotid swellings or anything, any malar rashes or anything over the face. So-
If the patient was compliant and he was able to open his mouth,
I'm sorry, sir.
if the patient was this patient is drowsy
Okay.
Oral
or
hygiene.
irritated.
Also, we have to check for
Okay.
the oral
Anything
hygiene.
else? Anything else in the mouth you might be interested in?
Any malampati is we have to see for the tonsils and malampati grading.
Dryness of the tongue.
Tongue.
Dryness of the tongue.
Yes.
Okay. So you're talking about capillary refill, how important.
Yes.
The same is
Hepatitis.
your tongue tells you a lot as well, not just cyanosis, also about the hydration status.
Hydration
It
status.
might tell you the history about some of the infective causes also, but more importantly, more commonly, you need to know how hydrated the patient is. Yes, this
Yes.
might just be purely a dehydrated patient from viral fever who's drowsy. Yeah.
Yes.
So you know, and then you can go to JVP. Then you go on complete a general examination.
The JVP and then the chest, over the chest wall, we have to see for any spine navies or any rashes or rashes, and then in the fingers, we have to see for any clubbing, basically clubbing or cyanosis again. Then hands again, palmar creases have to be examined, and then lymphadenopathy all over axillas and all the specific areas lymphadenopathy. Legs, any pedal edema is there. We have to check. And
Again, that cold clammy extremities and skin turgosity.
skin turgosity for.
When was the last time we did all this in real life? Now, let's be honest. When was the last time we did all this?
Yes,
It has to be done every day for every critical care patient. Yes?
Yes, sir.
Not just the blood tests that come and they see the monitor and right. Every patient has to have this general examination every day, especially on arrival of a new patient.
Yes.
Only then you're going to pick up those signs. We don't need to become, investigative doctors from just investigations.
Yes.
So these are the, key things that we must do for each and every patient. And that's the time you are going to pick up the clues. So your general examination is as important as your history.
Yes.
Okay?
Yes, sir.
Then you can spend details about your cardiovascular system with your the capillary refill and respiratory system. Was the patient tachypnic?
Yes, sir. 26 was the respiratory rate, mildly tachypnic, sir.
So that's again a positive finding, a very important positive finding for an intensivist.
Yes.
Yeah, there could be hundreds of causes for that. Okay, so you've narrowed from till now, just summarize your patient. What have you got? Now that
So,
you have history and examination.
okay, sir. So he is a 31-year-old male with ill comorbidities, alcoholic, resident of Nagar Karnool, and he is a teacher. Came with a history of fever, headache, and vomitings for 7 days with altered irrelevant talk for 1 day, sir. So, and with on examination findings, there are respiratory system. There was right infrascapular crepitations, and the central nervous system examination is showing towards drowsy, arousable patient with meningeal irritation, signs of meningeal irritation and bilateral plantar extensors.
Okay, so how long has been? Where is this patient? Emergency or ICU?
Later on, he's in the ICU only, sir, later.
He is in ICU. Okay, how
Yes.
long has he been in the hospital now?
And now he has been discharged from our hospital to rehabilitation center, so post tracheostomy.
Oh, okay. Okay, carry on.
Yes. So at this point, we have thought of meningoencephalitis with aspiration pneumonia was the one of the probable diagnosis, differential diagnosis, sir.
So, Dr. Jivan, once, so
Yeah.
your previous slide, you have mentioned that there are certain positive signs.
Yes,
So, in the in CNS examination,
yes, sir.
so there's a Kernig's and Brudzinski sign.
Yes,
So,
sir.
they are like how you elicit these two, and what
So,
are the significance of it?
sir, kinetic sign, we will flex the hip and flex the knee, and later we will on the extension of the knee beyond 135 degrees centigrade, 135 degrees. If there is a pain, that is a
Back pain and neck
positive
pain, it's
kinetic
positive.
sign, sir. In Brudzinski's kind, when we flex the neck, then there will be a flexion of the
Hip and
knee
knee
joints, sir. That is Brudzinski signs.
So ultimately, that will indicate this to just prevent the further meningeal irritation, because
Yes,
already meninges their infection. So you see, these signs are like when they are prescribed, they are described when there are like almost pre-antibiotic era, where they say there are florid meningitis situation is there. So
yes,
these signs will get to know. But nowadays these signs are quite rarely will know, because every, and like whenever the patient encounter in any hospital, like small or tier 2 or any hospital, they gave some of the other antibiotic. So eliciting this sign is rather difficult, I'll say.
yes,
So if it is still there, then means there is a profound meningeal irritation is there.
yes.
Okay. Take care.
Okay.
You expect this patient to obey your commands?
So at this point, he is obeying, sir. Probably, as Sir said, he should be in a non-obeying state. But we have
Okay.
elicited, sir. We have elicited the signs, sir. They were present, sir.
All right. Okay.
Yes.
Carry on.
So we have sent our initial investigations of ECG, ABG, and blood glucose and complete blood counts and renal function tests, sir. So ECG is showing sinus tachycardia, no STT changes, sir, at initial. And arterial blood gas analysis was showing pH of 7.47 with PCO2 of 30 and PO2 of 72 with bicarb of 24, lactates of 1.7 unremoved, sir. The point of care ultrasound findings were good LV, eyeballing was good, sir, and no ARIA-RV dilatation with IVC more than 50% collapsing, and no pericardial effusion, pleural effusions, and no shed sign at that point, sir. And two blood cultures were taken, and empirical antibiotic therapy of injection ceftriaxone 2 grams IV BD and injection of vancomycin 1000 mg IV has started. So the initial
Stop here. At your slide. Okay. So you've done some basic investigations and you've given antibiotics now. Go back
Yes.
to your previous slide. Okay. Have you done this CT brain EEG as well?
Yes,
Yes,
sir.
okay.
Yes, sir. Next slide, please. Yes.
Okay. All right. Carry on.
And these are the initial lab values. So as the initial lab values are hemoglobin of 12.4 and PCV of 37.4 with total leukocyte count of 6,370 with platelets of 1.35 lakhs. Peripheral smear normocytic normochromic. Our tropical fever workup shown came out to be negative, sir. Blood urea of 35 and serum creatinine of 1 and mild hyponatremia of 132 with the CUV and LFT and viral markers are negative. And so as patient had recent history of alcohol intake, thiamine was also added along with the antibiotics, sir. Then CT brain was done. After that, we have gone for lumbar puncture and CF was sent for analysis, sir. And the CSF analysis was showing slightly hazy appearance with 1200 cells more of lymphocyte rich, 95% are lymphocytes with CSF sugar going to be 37 mg per dl with at that point of time the blood glucose was 96 and protein of 214 mg per dl and ADA levels were 19.27 and our gene expert and film array panel came out to be negative.
Okay. Tell me the relevance of CT scan here.
Sir, CT scan will helps in identifying any that means whether it is any stroke is causing a similar kind of features or any space occupying lesions are there, any possible raised intracranial pressure features are there, or sometimes whenever there is a seizures and altered sensorium, seizures and immunocompromised
So
state.
which stroke do you see high grade fever for 3 days? So you are at investigations point. Go back 2 slides.
Yes, sir.
Go back. Go back, please. Go back, please. Go back, please. Let's stay at this slide.
Okay.
So from this point, you did all the investigations.
Yes.
At this point, are you worried about subarachnoid also and stroke also?
Yes, subarachnoid hemorrhage also possible with headache, altered sensorium, and there could be a fever, sir. So to rule out that also, we have done CT brain, sir.
How many subarachs have you seen coming with just with fever of 3 days?
Very few cases only, sir.
And even if they tend to have a low-grade
Low-grade
fever.
fever only will be.
But our patient
Unless they've had a subarachnoid for a week and they have been treated in some other hospitals, maybe. But
Yes.
as a first presentation, unlikely.
Yes, sir.
Yes.
But here it is nearly 1 week of course.
Okay, I take it. If it is 1 week, all right.
Yes.
And what other strokes are you thinking?
There could be in pontine hemorrhage also there is a possibility of high-grade fever, sir. But patient would not, the 1 week without any supports, he could not be sustained.
How
sir.
many cases of pontine hemorrhage fever have you seen?
Sir, I didn't get sir.
How many cases of pontine hemorrhage fever have you seen in 4 days? Presentation. Common things happen commonly, okay?
Yes, sir.
So just don't go for the last one on the list.
Yes.
So at this stage with fever, altered sensorium, with your presenting signs, if you're worried about subarachnoid hemorrhage, you are going, or a stroke, you are going down a different length.
Yes.
Okay? Then your CT becomes imperative. But if you're going down an infective line of an meningoencephalitis, what is important?
So whenever there are seizures, increased altered sensorium and any immunocompromised patient, whenever there is any signs of papillary edema, then CT is required before lumbar puncture,
So
sir.
if none of these are present, then we should first go ahead with lumbar puncture.
No, that's why I brought you to this slide. So what is the most important step in the ladder for a meningoencephalitis patient? If that's your first one as a differential,
Yes.
what is the most important thing that will affect mortality?
Starting the empirical antibiotics important.
Okay, good. So what is the timeline? Are you aware of any standards or timeline?
Within 1 hour of onset into the hospital by taking the...
Within 1 hour.
Yes,
Okay.
sir.
Dr.
Before that,
Durgesh,
we have to take 2 sets of blood cultures. And
let's ask the pure intensivist, Dr. Durgesh. 1 hour, is it fine for you?
whenever you encounter a case of like this, probably meningitis, the guidelines say 1 hour, but it should be at the earliest. Whenever you
Absolutely.
think of meningitis or as you already evaluated and you came to a diagnosis that this patient or my patient is probably having meningitis, meningoencephalitis, you should not be delaying the further test, or you should pushing the antibiotics. Okay, then but look, yeah, the ladder is you have to draw the culture. You have to, as already discussed, there are certain points where you may think that your lumbar puncture may be hampering and all. So put on draw the blood culture, give an antibiotic. Then you are still thinking that your LP because of probably might have, because our literature says very rare chances that you will be some SOL will be there and you will be herniating syndrome in that situation. But the culture, blood culture and antibiotic should be in at the earliest.
Yeah.
Okay, then probably then lumbar puncture comes. But if already, as already a few points you mentioned, when the patient is having immunocompromised state or initial presentation which is very atypical for your meningitis, or to begin with patient is having seizure like activity, or the patient is known case of any immunocompromised or something, or some bystander is giving some history, in that situation probably a CT, that also quick CT will give us some flu idea, and on lumbar puncture. So so next slide please. So what CBC, what you'll see, and CBC, what you'll get to know?
So in CBC, the clues could be if there is any raised WBC counts.
Apart from that,
Peripheral smear.
So, and there is any thrombocytopenia, it can give a clue towards any tropical fever, sir.
peripheral smear, what is the about the especially sepsis or in the peripheral smear, what extra it will give it information?
We get a shift to the left, sir, with
To left.
toxic granules present.
And band forms the toxic granules, if they are present, that it directs towards the infectious cause, sir, in peripheral smear.
Okay. The other
And any any malaria parasite can also be seen in the peripheral smear, sir.
Anything regarding platelet count? So what, just for what the platelet count, any contraindication for lumbar puncture? So you say we are going to, where you think that any contraindication apart from already we discussed SOL or anything. So where you think that the LP should be contraindicated?
If there are any epidural abscess or skin site infection in the L3, L4, L4, L5 area, sir, in the spinal region.
Okay, and what platelet count considered to be cut off? Suppose
less than 50,000 is a relative contraindication for lumbar puncture, sir.
Okay. This patient, why you need what is the significant serum glucose?
Sir,
Comparative
comparison of the CSF glucose to blood glucose will give you an idea towards bacterial meningitis or viral meningitis. That ratio is important in this setting, sir.
Have you ever done any CSF lactates?
Yes, sir. In this case was 3.19, sir. We have.
But it is there in the.
We missed it place, sir. This was 3.19, sir. CSF lactating.
What it tells us CSF lactates and all?
So CSF lactates of more than 3.75 to 4.5 range will direct towards the bacterial meningitis, sir.
Okay. So how will you see the, suppose the CSF picture is there, how will you differentiate broadly what type of picture you are seeing, like bacterial or tubercular, viral, or something fungal?
Yes, sir. So based upon the CSF, so if there are cells, number of the cells, if there are more of a polymorphonuclear cells with more than 10,000 cells in the CSF with more of a polymorphonuclear pattern with low glucose CSF glucose to blood glucose ratio of less than 0.4 with high protein in the with high opening pressure, so it could be a bacterial meningitis, sir. In viral meningitis, there would be counts would be relatively less and more of lymphocytic predominance with normal sugars with slightly higher proteins, and there is a normal opening pressure, sir. In case of a tuberculous meningitis, there are cells could be higher, but not that much higher of bacterial with more of lymphocytic predominance with low sugars and high proteins with raised ADA levels and slightly higher opening pressure will be present, sir. In case of fungal, in fungal also there is more of lymphocytic predominance will be there, sir. And with there is also possibility of high opening pressure. And in bacterial, there is gram stain could be positive, and in tuberculous, there could be acid bacillus positive, sir.
So basically, it starts with your ratio of the CSF sugar as well as and serum sugar. If it is less than 0.4, usually it is a polymorphonuclear predominance. Basically, it goes in the favor of bacterial meningitis.
Yes.
Similarly, suppose if it is WBCs are elevated with lymphocyte predominant with usually low sugar, it goes in tubercular. Tubercular and viral, probably the sugar level is viral sugar level is lower normal, or it is mostly normal, but the WBC count is not as elevated as in tubercular meningitis.
Yes.
Sir.
Okay. I think you know more about the CSF. Carry on.
And after the CSF analysis, we have also started on acyclovir 600 mg IV tricidate, sir, and also Levipil was added, sir. EEG was done. EEG was showing diffuse slowing of the electrical activity with probably encephalopathic pattern. It was shown, sir.
Okay.
And this
have you given any steroids?
No, sir. We have not
in your first go back when you gave with your blood tests. Yeah. So what's the role for steroids if you're suspecting meningoencephalitis?
Steroids in a case of streptococcus pneumonia, it was shown to be a mortality benefit, and also steroids has a role to decrease the neurological sequelae and auditory impairment, and also steroids helps in decreasing the inflammation, which and also increase the penetration of the antibiotics, sir. But there are certain studies saying that in a low-income country settings, that role of benefit of steroid is doubtful, sir.
Okay.
And if at all they have to be given, we will start with 0.15 mg per kg every 6th hourly for 4 days, sir. Dexamethasone.
Should be given
anything about the timing if you have to really
should be
give
given half an hour before the antibiotics, or at least
along
with the antibiotics. Or in case missed up, half an hour within 4 hours of giving the antibiotics.
So okay, that's a good answer. That okay, the role is, if there is anything that in CNS antibiotics are considered, it's meningitis or meningoencephalitis, especially TBM.
Yes.
Other meningitis, it is sketchy evidence, as you said, but there are still common practices to give it. But what is important is if you're really going to give it, there is no point starting the steroid after 8, 12, or even next day. There is no point. If you want to give it early. That is probably the only time it has some role, as you said rightly, to suppress the inflammation and probably help in the penetration of the antibiotic. So if you really have to give it, if you missed it and you've started antibiotics up to about 4 to 6 hours, you have a window to give that dose. Beyond that, actually it's not going to work. So whatever little role it has to start with first. But there are neurologists who will swear by steroids, especially with TBM and certain other categories. So that's in neurosciences, probably this is the only pathology where we really have some evidence, that is TBM and other meningitis, but it's got to be started. If you really want to do, the timing is key.
And in certain settings of acute disseminated encephalomyelitis also, there is a role of steroids.
So where in this meningitis picture you will not be interested in steroids at all initially? Any
Especially
specific
viral
meningitis?
In the setting of
Okay.
viral meningitis and fungal meningitis, sir.
Right. Okay. And can your patient have a viral or a fungal meningitis? What risk factors does he have?
So in this intake setting, there is fungal. One thing is could be the hospital stay could be sometimes possible, sir, outside hospital. But
Okay. Anything else in your history that
Alcohol
tells
intake.
you? Alcohol. He's a heavy
Alcohol.
alcoholic, you said. So he could be immunocompromised indirectly from alcohol intake.
Yes.
Yes.
So he gets prone to that. And I told you there is something in your social history that's missing for a meningitis patient or for any neurological patient. What were we missing in our history?
Vaccination history, sir.
Okay, maybe vaccination history. Anything else?
Travel
In the
history.
social
Travel history.
travel history. Okay, I accept it.
And
Anything
bite,
else?
any bite history, sir, tick bite or
Okay, anything else?
and any drug intake like cocaine abuse, amphetamines, any antipsychotic usage.
So where does he live? How does he live? What does he work? Where does he work?
He's a teacher by profession, sir.
Okay. So is he exposed to any fungus in their environment at the occupation? It could be a farmer. Like you said, okay, he's a teacher. I missed that. Is he lives in a house? Has he got any things which are prone to seepages, molds in an immunocompromised patient? So all those are important. So social history is equally important.
Okay.
Where do they live? How do they live? Where do they work? What work do they do? So it will bring out a lot of factors, risk factors for you to narrow down to. And yes, so if it is a fungal or a viral, you definitely do not want to give steroids at that point.
Yes.
Okay.
Yes.
One more
And,
history point. Sorry. So already, so history of like patient is having any, he's been exposed to any same similar cases. Okay, there is a community transmission of Neisseria meningitis is noted.
Yes,
So
sir.
from one person to other person, since he's become teacher,
Yes.
so probably there could be transfer also. That history also is important. Along with
Yes.
that, in general and physical examination point of view to be taken, any other source of infection. You see, probably there may be cases of endocarditis, or there may be cases of vertebral, anywhere, any body, there could be abscess. So that might get a hematogenous transfer to the meninges. So this seeding is also may happen. Or the patient might be having any previous or current year discharges that might lead to hematogenous spread and to the meningitis. So the history and all this should be also has a more elaborative, like joint pains also. In sometimes there are literature noted there are some septic arthritis in previous history, or that might lead to the meningitis also. So endocarditis, probably vertebral involvement, discitis, some joint abscess, septic arthritis. That are also some case reports are there that may lead to meningitis also.
Yes.
okay, so while we were talking of the timing, that other thing I wanted to say was we had said 1 hour max. But really, if you're really going towards a meningoencephalitis, you want the soonest possible broad spectrums to go in.
Yes.
You should not exceed 30 minutes target line. If you want a key performance indicator, if you want a target timeline, it's got to be within 1 hour. If you really are a good unit, you want it within 30 minutes.
Okay.
You know, your history is going, it might be subarach, it might be something else. One dose of that is not going to harm.
Yes.
If it is subarach or it comes out to be something else. But if it is really meningoencephalitis, the soonest that antibiotic and the broad spectrum antiviral goes, that's what can be life saving.
Yes.
Because the delay is already happened.
Yes.
So that 30 minute is a target that we put for ourselves. Second is, can you do a CSF? You can do a CSF,
Yes.
but the antibiotics should not be delayed by a want of a CSF.
Yes.
The equivalence is when you say that you have to do blood samples and take only then do cultures and give antibiotics for a general septic patients. What's the difference here with CSF and antibiotics?
So,
Up to
in
4
Will it
CSF
render CSF sterile?
Sir? I didn't
Will
understand.
will me giving the antibiotics at 10 minutes of arrival and
No,
then doing a lumbar puncture at 2 hours, will it make the CSF sterile?
no, sir. The literature says that even with the sensitive bacteria also, it takes 4 hours to reach that levels to make the sterile, sir, in the CSF. So we can have that window of 4 hours, sir.
Exactly. So what is crucial is to get those antibiotics in and then organize. If you're worried, then a CT scan will take 10 minutes.
Yes.
CT scan now is a two minute scan in every hospital. The arranging transfer takes time, but you can get it in 2 minutes, fine. Then you can have your peace of mind and you
Yes.
can do your lumbar puncture. But really, those herniations from lumbar punctures are rare and don't happen commonly. And let's say if your CT scan is not working, or if you are in a place where the CT scan doesn't exist, you might as well, and you have to send the patient somewhere else, you might as well give the antibiotics. And if there is no pupillary changes, no papillae edema, no lateralizing signs, no major signs of raised ICP, you can be rest assured the clinical signs are more important than a CT scan to tell you about raised ICP. So you can do a CSF and then send the patient, right?
Yes.
So the clinical signs are more important
Yes.
than a CT scan if you don't have access to one. So first is to get those antibiotics in. Then yes, if you have access to CT, get that done. That gives you a lot of peace of mind. But if you don't and you are in a smaller hospital and you have to ship the patient out, which is going to take 6-8 hours, you might as well do a CSF sample because you want to know what bug it is. Pro- Provided you do not have the signs, all the red flag signs that I just said.
Yes.
Okay.
And this is our CSF biofilm array, sir. That also
So,
came.
Dr. Jeevan, and here, tell me your antibiotic of choice. Which antibiotic you choose and why you chose?
So in the settings, ceftriaxone 2 grams IV coupled with vancomycin would be the choice, sir, because Streptococcus pneumoniae is one of the most important cause of meningitis, and in the settings like India where we have community
Streptococcus resistance of
streptococcal
more than
resistance,
1%, it's better to go
go
with
for vancomycin.
helps in better penetration.
And when we are suspecting if the age is more than 50, there is a suspicion of Listeria monocytogenes, then we have to go for ampicillin 2 grams every 4th hourly, sir. And if there is allergy to ampicillin, we will go for trimethoprim sulfamethoxazole, sir.
Okay, any other cephalosporin you can use or only ceftriaxone?
First generation.
Third generation only.
Sir?
I'm asking on only third generation
Yes, sir.
cephalosporin apart from ceftriaxone only, or you can use other generation. Ceftriaxone is commonly used and it is the dose is 2 gram BD. So that is why it is very easy and convenient along with the vancomycin.
Yes.
Okay, so other generation like ceftazidime and cefotaxime is also equally good penetration.
Yes.
But compared to like other group of like third generation cephalosporin has a very good and CSF penetration.
Yes.
So as you already said, if you are suspecting of there is a community having a step pneumonia more than 1% of resistance, so better to add a vancomycin. So we preferably give ceftriaxone as well as vancomycin.
And in settings of hospital-acquired infections, there is a possibility of pseudomonas. Anti-pseudomonal cephalosporins like cefepime also could be considered, sir.
Better like though consider, but in hospital setting there would be will prefer directly going to the carbapenem, especially only meropenem. 2 gram IV DI, that is the dose over a period of given of 4 hours.
Yes.
So like one more thing, how the stains will be helping you when
Yes,
you see if you send everything is done, you will go for staining also or needed or
We
not
have to
needed?
go for staining also.
Staining will go through.
Staining means that will give us some clue because you can speak with your microbiological like that I am sending a particular sample and just can you go and click through stain and give us what is the clue or what? So
Yes, sir.
Like if it is a gram-positive diplococci or gram-negative cocci or even gram-positive rods also, improving immunocompromised patient, this will give us a clue
Yes, sir.
whether what to start and how to go ahead with it.
Yes, sir.
Gram-positive diplococci, we have to suspect if there is any streptococcus pneumoniae. So if it's gram-negative, then it could be Neisseria meningitis.
And if it is gram-positive bacillus, there is more of Listeria
Listeria
monocytes, and gram-negative bacillus, it is more of Haemophilus influenza B, sir. Nowadays, post-vaccination, these are decreasing trends, sir.
Oh.
Yes.
Go ahead.
Okay, thanks. And on the day later that evening, patient got desaturated with 90% SpO2 with still with 10 liters of oxygen, and patient was also became tachypneic and ABG showing type 1 respiratory failure, sir. So there is a right lower zone shed sign was present on the focus, sir, and we have done ONSD. So optic nerve sheath diameter was around 4.8 mm. So in view of impending respiratory failure and with altered sensorium, patient was intubated with endotracheal tube of 8.0 mm fixed at 21 centimeters at the angle of the mouth, sir. And then EG samples were sent for gram stain and culture sensitivity, sir.
What was the ONSD at arrival?
This is what we have checked, say that on that day, that is the first ONSD we have looked at, sir, 4.8 mm, sir.
Okay, so this has no relevance to me.
Yes, sir, but probably it could have relevance in the ongoing scenario, sir.
So what should happen is that with your new stethoscope that you got with the ultrasound,
Yes, sir.
your neurological examination should have an ONSD at arrival.
Yes, sir.
Okay, then it makes sense.
Yes, sir.
You can only make sense of it when you know the trend.
Yes, sir.
So when you listen for the sounds in the chest, you must use your ultrasound. You did the full focus examination, but didn't mention ONSD at that stage.
Yes.
Or did I miss it?
No, sir. We missed it at that point, sir. Now, as their respiratory failure
So
is
if you had differential of a neuro patient and you did a focus,
yes,
you can start from the top itself.
Yes.
okay.
Yes.
Okay.
Point is, an ONSD is a trend.
Yes, sir.
Do it right at the point of first contact with the patient.
Yes. And the initial ventilator settings were volume control mode with FiO2 of 100% with a PEEP of 14 and a respiratory rate of 24 and tidal volumes of 400 with platelet pressures of 28 and driving pressure of 14, sir. At that point, post-intubation, the X-ray was bilateral infiltrates were showing, sir. So later on that day, with that settings, the ABG has shown to be PF ratios of 61, sir. So we have to start the patient on prone ventilation, sir, because it is looking like an ARDS, severe ARDS, with less than 7 days of duration with bilateral infiltrates and non-cardiogenic. The echo was normal and PF ratios of less than 300 with a PEEP of more than 5. So it is a setting of severe ARDS. So we have gone for prone ventilation, sir.
Okay, go ahead.
And ABG on day 2 during prone, the FiO with the FiO2 of 60% and the PO2 was 176 with the PF ratios were improved to more than 240 to 50, sir. And then again after 16 to 18 hours, around 18 hours, we have supined the patient. In the after supination of 4 hours, our ABGs were again showing all in PF ratios, sir. So we have to go for another proning session in the next day early morning, sir.
So generally, how long, if you prone a patient, how long do you leave a patient prone?
16 to 18 hours, sir.
Okay.
So again, after supine at the later evening, and at this time, the PF ratios were improved even in the supine position, sir. So we have, these are the X-rays of the third and fourth day, sir. So the ARDS picture is slowly improving, and now at this level, it is the picture is getting clear. So infiltrates were decreasing bilaterally. And so as the PF ratios were improved, we have tried for extubation. So we have given an SB trial, sir, spontaneous breathing trial, but we couldn't succeed in that trial, sir. So at that point, when we checked for the power, the upper limb powers were, in the shoulder upper limbs generally it is looking like 3/5 and lower limbs 2/5, sir. So we have suspected of IC intensive care associated weakness, sir. So acquired weakness. So at that point, the MRC scoring was around 36/60, sir. And next day we have, after discussing with our neurologist, we have gone for the nerve conduction studies, sir. The nerve conduction studies have revealed no significant derangements, like what are expected in the ICU associated weakness, like decreased snaps and decreased sensory neuron amplitudes and decreased the action potential and decreased compound muscle action potentials as such was not such significant in that scenario, sir. And the patient was still again bit drowsy, so we went for MRI brain next day, sir. That MRI brain was showing diffusion dictation with bilateral frontoparietal regions with and also involvement of central semivowel. So looking more of a meningoencephalitis, and also the less likely diagnosis, another differential could be acute disseminated encephalomyelitis, sir. So started on low dose of steroid, though the literature says there is requirement of high dose steroid in ADEM, but we are suspecting viral and this picture, so benefit of doubt, and also there is suspicion of this ICU associated weakness, so we haven't gone for full-blown steroids. So we have started a low dose of steroid, so and we have planned for tracheostomy as there is a possibility of prolonged recovery. And tracheostomy was done on the next day, and after that day, as the patient was slowly improving and the power
Okay,
also.
now I see what happened to neurology on day 8. So previous days I didn't see what was the neurology of the patient in terms of conscious levels.
Yes, sir.
I saw upper limbs and lower limb powers,
Yes.
but I did not see what was the arousal state of the patient.
During that previous 2
What
days.
happened from day 2 to
Yes, sir. During that period, as we are proning him, we have to, during the proning periods, we have sedate paralyzed him, sir. And in the after supination also, his sedation free period also, he was not that much conscious, sir. He was still a bit drowsy only, sir.
Okay. Just give me 1 minute. Dr. Durgesh, I just need to take a call. Carry on.
So what can you do in between when there is a you're going in between proning and supining? You're not able to access probably because you might have to give sedation and relaxation. How will you? What you can add your points to that the patient's the neurological status or is maybe intact or not probably worsening.
So during the sedation free periods, during the supine period, sir. So we will stop the sedate paralysis and we will assess for the movements of the limbs and any conscious levels regained. So and also at that point, as SAR said, ONSD as our new stethoscope, we can use it to further assess the any changes in the central nervous system changes, sir.
Yeah, so look, ONSD pupillary examination, and if you frequent doing on the TCD. So if you have a bedside
Yes,
transcranial Doppler, you will have a fair idea what is happening with the ICP.
Yes.
Begin with previously in the first of admission, you didn't do ONSD, you did just before the proning.
Yes, sir, because raised intracranial pressure can be a contraindication for a proning, sir.
So we have to have a serial ONSD monitoring. Okay,
Yes.
so probably that will have the more weightage rather than single value.
Yes.
And probably the TCD is also has a weightage because like TCD, that's all the single value will not have anything. What is the velocities, what is happening with the velocity will give us a fair clue what is happening with the what is happening to the ICP.
Yes. So especially in the settings of subarachnoid hemorrhage, the Lundberg ratio will be, Lindgard ratio will be calculating, sir, with transcranial doctor.
Okay, please proceed.
So at this point, we also thought of our neurologist, and we have thought of a post, it could be any post-infectious Guillain-Barré syndrome, any possibility also was thought of, sir, but NCs was not suggestive towards that, sir. And also the deep tendon reflexes were not absent or decreased, sir. So later we have tracheostomy and slowly power and over a period, next day. So power was slowly improved and he became conscious, coherent and obeying commands. So patient was hemodynamically stable and he was able to maintain on a portable ventilator. So in view of prolonged recovery, he has been sent to rehabilitation centers. And our probable final diagnosis was meningoencephalitis with aspiration pneumonia, type 1 respiratory failure, severe ARDS,
Status post
status post prone ventilation to prone ventilation, status post tracheostomy for weaning difficulty, and query acute disseminated encephalomyelitis.
Okay, can you summarize your case for me, please?
Yes, sir. A 31-year-old male who is a teacher by profession presented with fever, headache, and vomitings for 1 week, and later, after 3 days of treatment, he has also developed a 1-day history of irrelevant talk. Presented to our hospital with positive findings of right infrascapular crepitations with drowsy, arousable, and bilateral plantar extensors, neck rigidity, and Brudzinski and Krennic signs positive. And on further evaluation, the CSF is the CT brain was found to be normal. The CSF is more of lymphocytic pleocytosis, which could be either viral or viral bar tuberculous bar. Sometimes then ADEM also can have an lymphocytic pleocytosis. And then the patient has, because of the probable aspiration pneumonia, he has developed into severe ARDS, requiring 2 sessions of proning. And as there is a difficulty in weaning, probably because of the ICU acquired weakness, because muscle power is less. So we have gone for tracheostomy, and as the patient has clinically improved, except for this, the brain has to be improved, and this we have sent him for rehabilitation centers.
Okay, so few questions before I ask my question. There's some questions on the panel here. Did you give any steroids for ARDS? I think you did. Did you?
No, sir.
No, you did not. Okay.
Because we are suspecting viral, so in that scenario, we have tried with the prone ventilation. As the prone ventilation is giving results, so we don't want to go for the, we didn't opt for that, sir.
Okay, and another question is, what about vancomycin? Is there a role for vancomycin initially? Does everybody get it, or along with ceftriaxone?
Yes, sir.
Especially in the setting of Listeria monocytosis, if it is proven, and there is no role for vancomycin as such, sir. And in the setting of Haemophilus influenzae, which is penicillin sensitive Haemophilus influenzae also, generally ampicillin is sufficient.
Okay, and somebody feels you've done a trachea too early.
So
what do you think? Did you do a trachea too early?
So, I mean, there is the difference of opinions, sir, 7 days versus 14 days. But in this setting, as we are suspecting that is there is a viral meningitis versus blood culture negative, CSF negative meningitis, at least 14 days of antibiotic or 21 days of antiviral is required, and the power is on lower side. And there is also a possibility of acute disseminated encephalomyelitis. Probably it may take prolonged recovery. So we have gone for tracheostomy so that the weaning could be easier and the rehabilitation could be easier for the patients.
Okay, early or late, I think you've justified it well, so I'll give it to you. Okay, Dr. Durgesh?
So have you ever encountered, this is community acquired, so you continued antibiotic for 2 weeks?
Yes,
Yes,
sir.
Okay, so you are the antibiotics were followed it till he was in the rehabilitation center.
because
Day 7,
we
day
did-
8, no, patient was discharged and to rehabilitation
yes,
within day 8 of hospital admission, I suppose.
we have sent on the 7th day, sir.
That's what. So the antibiotics are at least minimum 2 weeks.
Yes, sir.
Yes,
2 weeks.
sir.
Yes,
2
sir.
weeks. With
We have
antibiotics,
with
we have
antibiotics only
sent,
we have
sir.
sent the patient, sir.
Okay.
And we have given the strict advice as per that as a viral also suspected 21 days of acyclovir and CSF negative meningitis, probably bacterial meningitis, there could be requirement of 14 days of antibiotic. So we have advised, sir.
What about hospital acquired, suppose post operative or post neurosurgery meningitis? What could be your initial antibiotic of choice?
So in that meropenem, carbapenems could be the
Drug of choice.
choice, sir. And
But
also when
specifically,
sir, I didn't get, sir.
specifically in the carbapenem, that to carbapenem, which specifically there are 3-4 carbapenems are available. Which carbapenem and how much dose, how much duration?
Meropenem 2 grams IV thrice daily, sir.
How much duration?
Uh,
Over each dose has to be given. It has to be given over a period of 4 hours.
yes, sir, over 4 hours,
Yeah,
continuous
yeah,
feeding.
yeah. So that is one thing. Next thing, look, and our
Thank you, sir.
predominant flora is gram negative. I'll suggest to add cholesterol also,
Yes,
because here the literature says more the favorable in cholesterol compared to polymyxin B.
yes,
So 9 million unit and 4.5 BD followed by loading dose.
yes,
And probably vancomycin is also there. If the patient is might be having VP shunting or anything, there vancomycin is also there.
yes.
And have you any exposure of about intrathecal cholesterol or anything?
Yes, sir.
Yes, sir.
Intrathecal
So
cholesterol,
intrathecal cholesterol also plays a role. So probably
only
if
at
I
25,000 units or 10 mg equivalent is given to once daily, sir, intrathecally. And we have to clamp the this for 30 to 60 minutes, sir.
okay, and in some cases there is TG cycline might also be if the bacteria is sensitive.
Yes,
Few antibiotic like vancomycin, aminoglycosides, cholesterol, and TGs also can be used. TG cycline is recent addition that is also in experimental basis, not very large data available, but you can try. And there is a patient is probably in XDR, so you can give a 10 milligram intrathecally as well as IV also. You have to give IV high dose TG 200 stat followed by 100 milligram IV PD.
yes.
Yeah.
Okay, great. So there's another question. What are the role? Is there any role of anti-edema in meningitis?
So as such,
Anti-edema.
anti-edema measures are as such not seen in the routine standard of care of treatment for meningitis, sir. So if there are any clear-cut signs of cerebral edema with raised ICP,
then we have to go ahead with
possibility of
anti-edema.
role, sir.
Of
But
course.
as
So edema can happen. So if their meningitis leads to blockages, so what are your goals of management? Are supportive therapy, identifying the causative organism,
yes,
and looking after complications.
yes.
Yes.
So if a complications
So,
were to happen, the
hydrocephalus,
list of complications will include hydrocephalus, raised ICP.
raised
So
ICP.
obviously there is a
Yes, sir.
Risk is there.
role of ICP management is
Yes,
or
sir.
raised cerebral edema management is pivotal to the entire supportive management. It can start at the beginning or at the course of the journey.
Yes, sir.
Those basic things of neurocritical care will stay.
Yes.
And how would you manage anti-edema measures? Let's say there is
So,
cerebral edema now, or there
hyperosmosis.
is hydrocephalus.
Hydrocephalus, if it is very large hydrocephalus, we may have to go for shunting, sir. Ventriculoperitoneal shunting.
You will put a shunt in a patient with meningitis straight away?
So,
Intrathecal.
infectious, so intrathecal antibiotics will decrease the infectious dose, and also anti-edema measures also can help to decrease, sir.
If there is hydrocephalus with meningitis, the question is, would you put a shunt?
Mm. So we haven't come across that scenario, sir. So please.
Okay, what is a shunt? Thank you
So
for being honest. You've not come across. That's absolutely fine.
yes. So as there is a increased volume in the ventricles, which would be compressing the brain parenchyma. So we are diverting that fluid towards the another. We are making a conduit to
remove the
that
fluid.
yes, sir.
Remove the excess.
Excellent. So that's what shunting from A to B.
Yes.
But you are saying you are putting a conduit. Yes. So is it a patient's own or is it a foreign body? It's a plastic tube, na? You're going to put it from the brain, and you said you're going to put it into somewhere in the body cavity.
Yes.
So in florid infections, would you put another foreign body?
No, sir. It can even lead to again
Worsening.
device-induced infection, bloodstream infections also can be increased, sir.
So the a shunt infection is a disastrous consequence. It
Yes.
takes ages to recover from it,
Yes.
right? So you do not introduce a foreign body
Yes.
at the risk of infection. Neither the patient will heal, nor the shunt will be successful. So what do you do then instead?
So we'll go
You still have to take the fluid out.
So then the role of hyperosmolar therapy.
Before that, no.
And
What stage?
Head elevation.
We can have that.
Okay, very good. So the
final
most
tapping.
important step is head elevation. Okay? You can become a neurosurgeon yourself.
Yes,
That
sir.
is one thing that is very poorly done across all ICUs.
Yes, sir.
You'll see patients lying flat everywhere.
Yes, sir.
So you got to get the head up. That's the best way to do, but that's very transient.
Yes, sir.
But what is permanent way of shunting?
Spinal tapping, drainage, lumbar drainage can be.
No, have you heard of something called an EVD?
EVD, yes.
Yes, sir.
Extra
What does EVD stand for?
extraventricular drain.
Okay,
With
so that is your
flap.
temporary buying measure to divert the CSF.
Okay.
Yes.
This time you're diverting it out of the head, out of the body.
Yes.
Yes, sir.
Okay, because it's not the correct time to put a shunt. If the patient recovers and it is still dependent, he or she is still dependent on the EVD, then you can convert to a shunt.
Okay.
Right? What is the problem of having an EVD? Complications of having an EVD?
It can also be
Source of infection.
source of infection. Can be.
Sure. So it can bleed and it can also get infected. So EVD care bundle is essential.
Yes, sir.
That you look after the EVD just like any other foreign body properly.
Yes.
So it will take care temporarily of the hydrocephalus.
Yes.
If the patient improves, meningitis improves, might as well you take the EVD out, it might not need the shunt. But as often do we see, if there is an ongoing hydrocephalus as a sequelae of meningitis,
Yes.
the patient might need a shunt. So shunt has to be done when there is no active infection or signs of infection in the body. Temporary measure is an EVD.
Yes.
So that's one measure. You were talking about some other measures, anti-edema measures. Tell me about those.
Hyperosmolar therapy like mannitol and 3% is saline, NaCl.
Okay. So if you work in pure neurocritical cares, what are we any benefit of one over the other, or?
Now it is more towards 3% NaCl is trend is towards 3% NaCl, so favoring towards.
Okay, so most would favor that. Okay,
Yes.
so head up important, hypertonic measures are important, hyperosmolar measures are important, EVD is important.
Yes.
So all the good supportive things are as important.
Yes.
A good basic ICU care is important.
Yes.
And when you put an EVD, of course, then you can give your intraventricular drugs as well.
Yes.
But what is important is who gives those drugs. What is important is how the drugs are given,
Yes.
how the EVD is handled.
Yes.
If you handle a central line very poorly, the patients are bound to get all the acinetobacters.
Yes.
If you handle an EVD poorly and anybody and everybody has access to the EVD, the patient is never going to recover.
Yes.
So an EVD care bundle, how to handle the EVD, who handles the EVD, sterility is all maintained is very important.
Yes.
All these small little things have a huge bearing on the outcome.
Yes.
All right?
Yes, sir.
Okay. So that's all from my side, Dr. Durgesh.
That's it. Only thing is that first and foremost, evaluation, putting on differential diagnosis and having high suspicion, and adequate management of early antibiotic therapy, and culture based, or if not clinical suspicion based, adequate doses of antibiotic, especially in meningitis, where we'll have adequate prescribed doses in as per the literature we have to give. That's it.
Sir, a couple of other questions here. One is the role of seizure prophylaxis. In this patient. One question. The second question is regarding the role of MRI based on the pattern of involvement in MRI can affect uh, pathological organism.
Yes. So we have to answer, sir.
I'm looking for the experts.
Yes.
Sorry, I didn't get the first. I got the second question. Role of MRA in the pattern.
In identification of the the etiological diagnosis, like
Sure. So MRA, I think it comes down the line. It won't be the first line. It probably has got more value in tuberculous meningitis, where there are small infarcts that goes in favor, or vasculitic meningitis. So there it probably becomes relevant. But in our practice, we don't see it happening straight away.
So, like one more point, MRI, look, MRI is already, it is not a main diagnostic modality for meningitis. MRI is specifically done when the patient is like already post-operative, when the, look, this, there is a, like suppose trauma patient who's already underwent decompressive cranectomy, when the sensorium is not getting better. Suppose the MRI with contrast might give a clue that patient might be having periventriculitis or something. There the role of MRI come, but not an initial part of the diagnosis. And in tubercular, as I already said, there may be exudate, there will be diffusion restriction, or there may be some vasculitic picture is there. Here, more common towards the patient is going towards a additional point towards the tubercular meningitis. Or in suppose patient who is already having immunocompromised state, where you will see in contrast multiple ring enhancing lesion. There, in that situation, the role of MRI comes, not initial.
The last question would be, how commonly do we use TCD in the management of these kind of patients with meningoencephalitis? Probably Durgesh and Gaurav sir, probably working in neuro ICUs would be the best persons to answer this question.
I think Durgesh mentioned about TCD already. Is that you? Sorry, Durgesh, take over.
So now look, as ultrasound is our stethoscope. Like nowadays, it has been replacing our stethoscope. So you see, when you see, there's a question is like how frequently you auscultate a patient. So look, if you find any changes in the patient, of suppose the patient is having Krebs or anything bronchospasm, so like this, I think we have to develop a habit that if you like, these are the one is that the slightly learning curve is slightly some tedious, like ONSD looking frequently, and TCD. It is not like we are everything we are depending upon that. Yeah, it will give us a fair clue regarding the ICP. That is not the only thing that will tell us exactly, but it will give us a trending. So single value also doesn't have any meaning, but has a give us a trending that whether what is happening to the ICP. So when here where the situation, like suppose we are proning a patient where we think that probably there something happening with the brain. So here will give us a fair idea that what ICP might be increasing or it is like normal. That will have a fair clue. That's what a TCD or ONSD will be helping.
I agree with that. And I think if you were to summarize, I think you've presented well, and I would were to pass you, you would pass this. But you need to focus on the history part as to what to bring out. You need to focus on your initial assessment, where general examination is as important for any patient. Your pointers can take you to your differentials, and if your differential comes out to the territory of, remember, classify and die. Meningoencephalitis is a class 1 emergency. Antibiotics are a key. The history will guide you towards the class of antibiotics also, where you are heading. And then you need to get to the CSF analysis. If you can culture and isolate your bug, Do remember tropical meningitis is in our country. Do remember TB meningitis, because the drugs are very important, the doses are very important, how they are given again are very important. Also remember gram negative hospital acquired meningitis, which is a bane right now, especially with foreign bodies, patients who are regular visitors to neurosurgical units or neurosurgeries. So they are becoming very difficult to treat. So you need very high doses, you need for very long time, and sometimes you need intraventricular doses as well. Do use TCD, do use ONSD, do use EEG as well when you are looking at encephalitis pictures, because what you are trying to do is offer supportive care, and controlling that seizures in the background is as important supportive care, which you might not see, and there could be non-convulsive seizures happening all the time in the background.
Yes.
So providing that specialized care in the background while the patient recovers from the meningitis is important. And the antibiotics are for a long time, so you need to look at access, you need at basic good ICU care in the background. So that's all from my side. Thank you very much for presenting. I think you've done well.
Thank you.
Thank you, Gaurav sir, for joining us, and thank you, Durgesh. And
Yeah.
I do agree with Gaurav sir that Jeevan and Hina, you've done a good job. Thank you. Thank you.
Yeah. Okay.